So, skin allergies. We have contact allergic dermatitis, which is a cell-mediated hypersensitivity reaction, and it occurs some hours after the contact with culprit object. It's characterized by red itchy rash caused by substances that have come into contact with the skin, so an allergen. The all possible causes can be soaps, cosmetics, fragrances, jewelry, and also possibly an occupational disease. The main contact allergens tested with patch test could be metals, like nickel and chrome, dyes, 4-phenylenediamine, latex and substances used in latex processing, topical drugs, formaldehyde, perfume, preservatives, like parabens. So as you can see there, they can be the cause of contact dermatitis on the lips because of the application of some product, and in the case of contact dermatitis the inflammation is also going near the application site. For what regards the patch test, you are applying on the back a patch with all the different haptens and you keep it for 48 to 72 hours, and you see that exactly in the place where allergens are put you see a rash with vesicles. We have atopic dermatitis, which is a chronic inflammatory disease that affects the skin with a typical alternance of exacerbation and remission. So the patients typically sometimes have dermatitis and sometimes are totally free from symptoms. It's a multifactorial disease involving a genetical predisposition plus an environmental interplay. The genetic factors include the genetical predisposition for atopy and production of IgE in response to common environmental protein, a mutation in the gene responsible for filaggrin codification, that is a protein present in the skin, and some mutations for these genes are very frequent in patients with atopic dermatitis and in patients that present problem of incomplete barrier of the skin. Atopic refers to the inherited tendency to produce IgE, sometimes associated with asthma and rhinitis. It's characterized by itchy rash and dryness of the skin. Prevalence of 10% of children less than 7 years, but it can also persist in adults, and when it persists in adults, we have more severe forms of atopic dermatitis, very difficult to treat. Major features are intense itching, characteristic rash in locations typical of the disease, in particular in children. We have a face involvement. In adolescents, we see the junction involvement of the arm and behind the knee, and in adults, we have mainly symptoms of the face. We have also chronic or repeatedly occurring symptoms and personal or family history of atopic disorders, so eczema, hay fever, asthma. The minor features are early age of onset, dry skin that may also have patchy scales or rough bumps, high levels of immunoglobulin E, an antibody in the blood, numerous skin creases on the palms and or foot involvement, inflammation around the lips, nipple eczema, susceptibility to skin infection, and positive allergy skin tests. There could be again some mutations in filaggrin genes that lead to permeability defects, and a lot of common allergens are present in the environment. We have also chronic urticaria, which is less when it lasts more than 6 weeks. In 60-80% of these we have spontaneous urticaria. Most of the rest, 20%, have a physical urticaria, so dermatographism or cold urticaria. 50% of cases of spontaneous urticaria are idiopathic. The other 50% are autoreactive in nature and often have associated thyroid autoantibodies. Although spontaneous urticaria is not an allergy, in 10% of cases symptoms are exacerbated by food additives, especially sodium benzoate in fizzy drinks or tatrazine in food coloring, or aspirin and other NSAIDs. We have a slight female predominance and can affect any age, although 50% present between the ages of 20 and 40. 25% of patients have an atopic background, and the symptoms can be, although the condition may persist for several months or in some cases years, individual lesions generally last between 30 minutes and 4 hours, can have additional elements of physical urticaria such as dermatographism or delayed pressure urticaria. Angioedema will affect some patients but is rarely life-threatening. As a natural history, 50% of patients with spontaneous urticaria can expect to be clear in 6 months, but some persist for years. There are also some blood tests to be performed. We have a blood cell count, PCR for suspect of infection, TSH and thyroid autoantibodies, because in many cases chronic urticaria appears together with chronic autoimmune thyroiditis, electrophoresis, and total IgE. Helicobacter pylori association and resolution after the eradication of the bacteria. When angioedema coexists, we should assess the complement C3 and C4C1 inhibitors. Once urticaria has been excluded, you should perform intradermal reaction with autologous serum and plasma, and this allows us to perform diagnosis of autoreactive forms of chronic urticaria, because it means that either in serum or in plasma you have some factors that induce the granulation of most of mast cells in the skin. As a therapy, we can use antihistamine 1, so cetirizine, levocetirizine, loratadine, rupatadine, steroids like prednisone, methylprednisone, 0.5 milligrams per kilogram, antileukotriene, montelukast milligrams, cyclosporin, 2.5 milligrams per kilogram, anti-IgE, omalizumab. It has been used but is not available yet in routine settings. It has been used in trials and up to now it seems to be very effective. And we have also angioedema due to ACE inhibitors or deficit in C1 inhibitor. When a patient arrives with angioedema and in particular with a localization in the oral mucosa, you have to think about ACE inhibitor, antihypertensive drugs, or a deficit in C1 inhibitor. The patient can have very severe life-threatening reactions with the complete occlusion of the airways, and this happens for mechanisms that involve not histamine but bradykinin. This explains also why the patient is not responsive to steroid treatment and needs more specific therapies. The therapy consists of suspension of the ACE inhibitor and, if hereditary forms, icatibant, which directly blocks bradykinin auto-injector.